Good afternoon, everybody. Today we're going to be talking about my PhD title, New Perspectives on Transplantation in the Treatment of Cancer and Diabetes. So my name is Arnold Marchis. I'm a medical doctor and a graduate of biomedical sciences and currently a first year PhD and master's student. These are my supervisors, and my mission is to offer the best medical or surgical options to cancer and diabetic patients and improve the level of healthcare offered in Eastern Europe and more. Our mission to achieve that is by learning from the very best in the field, finding knowledge gaps and improving current standards and policies for the treatments of cancer and diabetes. So we have begun 2 projects. Without further ado, I'll start with the first. So this is called Comparing the Effect of Pancreas and Islet Transplantation to Insulin Therapies on Glucose Metabolism in Patients with Type 1 Diabetes undergoing renal transplantation. This is a systematic review and meta-analysis. So a little bit about the background. Well, diabetes accounts for around 45% of chronic kidney diseases. In some countries, 40% of patients with diabetes are listed for renal transplantation. Pancreas and islet transplantation are considered the only cures for type 1 diabetes, as they are the only interventions that can induce remission. Pancreas transplantation is closely related to renal transplantation, as in 89% of the time it's done simultaneously with it, and in 5% of the time done after. Insulin therapies, however, are getting better due to the pharmaceutics and technology industries which are advancing and deserve to be compared constantly to these established transplantation methods, and with good reason, because as you can see on the figure on the right hand side of the screen, diabetes is set to grow exponentially in numbers in the next 15 years or so. So we have 3 illustrations. These represent the interventions that we're going to be looking at, and our aim is to determine which therapies can improve glucose metabolism and other outcomes. So the population, patients with type 1 diabetes undergoing renal transplantation. The interventions that we'd like to compare between each other will be pancreas transplantation, insulin therapy of any form, whether it be an older method or a modern form, and islet transplantation. Our primary outcome is glucose metabolism in the form of HbA1c, but we've also tested other parameters. We have multiple secondary outcomes in which we've included renal function, cardiovascular risk assessment, as well as overall and graft survivals too. Our clinical question: does insulin therapy offer better glucose metabolism compared to pancreas or islet transplantation in our population, patients with type 1 diabetes undergoing renal transplantation? Well, our hypothesis is that less invasive methods are not inferior to invasive methods, or at least will not be in the very near future. So what's the clinical or research implication of this? Well, the level of surgical need for patients with type 1 diabetes may decline in the future, and that's if patients in the future opt for insulin therapies rather than transplantation. So we have a flowchart selection and a search key on the screen. Let's begin with the search key. So we have 3 domains. The first one refers to the diabetes in our population, the second to the renal transplantation, and the third to the accompanying therapy. In our selection, we were left with 287 articles. So let's present some results. This is a forest plot that shows us HbA1c values at baseline and at 12 months of follow-up. So HbA1c, also known as glycated hemoglobin, is a blood test parameter that allows us to understand the amount of glucose in blood of a patient over the past 3 months. It's a parameter often used to monitor and to diagnose diabetes, and most healthy patients have values of under 5.7%. Patients in the pre-diabetes phase are considered to have values between 5.7 and 6.4, and most patients with diabetes constantly have values of over 6.4%. So what can we see? Well, we've got 25 studies that vary between retrospective and prospective studies that included 1,566 patients that received one of our interventions. In this case, it's pancreas transplantation specifically that was done simultaneously with the renal transplantation. And what does this data show us? To quickly adjust the heterogeneity, I'd like to mention that it can be mathematical due to the different number of patients included in each study, as well as the varying number the varying value of HbA1c in the pre-transplant phase. However, other reasons may be the patient characteristics may vary between the cohorts, as well as the differing insulin therapies that these patients may have received throughout their lifetime. Well, let's jump to the conclusion, to the results. So after 12 months, we saw a 2.93% reduction in HbA1c values. Now, this was consistent with a longitudinal study that we also did, where we analysed 6 follow-up time points, with a 2.96% reduction in HbA1c values after these time points. Now, this is not only clinically relevant, but statistically significant as well. These results were also presented in Dusseldorf, Germany, at the European Pancreatic Club's 57th meeting. So we'd obviously like to show you many more forest plots, but we're not able to, so I'm going to show you some summary tables. This is a slide that shows a summary of all the glucose metabolism forest plots that we have. Every grey row represents a different forest plot, and they each just show the results. Now, as you can see, there's a lot of red on the screen, which means they were statistically significant. We also have results from renal function and cardiovascular risk parameters, which we shall include in our article. And we are still waiting on the final results from the statistical team regarding the survival. So, just to quickly recap on our first project. Well, we've received around half of our figures. We're still waiting to begin the grade assessment because we can't do so without all of the final figures. However, we have begun the manuscript writing and we've finished the introduction and method section. So let's go into our second project. This is titled Comparing Liver Transplantation to Systemic and Regional Therapies in Unresectable Hepatic Malignancies. So some background. The liver is the most common site for metastasis. It's actually more common to have metastatic liver cancer than primary hepatic cancers. Up to 50% of colorectal cancers end up in having colorectal liver metastases. And the liver is actually the most common location for most cancers to metastasize in. The good news is, if you can call it that, is that 80% of metastasis cases are confined to the liver. The bad news is the majority are considered unresectable. Liver transplantation is an option for these primary or metastatic cancers in the liver. Now, sticking to these illustrations on the bottom, what we aim to do basically is just to assess the effectiveness of liver transplantation in different oncological diseases. Contrary to what we might have learned in medical school, that patients with cancer are not good liver transplantation candidates, recent studies show that results are getting much better. So our population is patients with unresectable liver cancer. The intervention will be liver transplantation. The comparative therapies will be the established therapies such as chemotherapy or radiotherapy, and our outcome will be overall survival. So our question, is liver transplantation the best option to treat patients with unresectable cancer? Our hypothesis is that liver transplantation is the best option for treating some forms of unresectable liver cancer. As we know, there are so many different types. And so what's the clinical implication? Well, more patients with unresectable liver cancers may be placed on transplant waiting lists, ultimately giving them a second chance at life that they may have not had before. So this is our preliminary search key. The first domain refers to the different forms of liver cancer, the second to the transplantation of the liver, the third to the comparative therapies, and finally the fourth domain will refer to our outcome. We have multiple key articles, we actually have more than what's on the screen, that include different forms of cancer. On the screen we have colorectal liver metastasis, a secondary form, as well as primary liver cancers. They all look at different criteria, such as the Milan, the Barcelona criteria, and the San Francisco criteria, and there are many to be included. We have not yet submitted this project on Prospero, as we are still waiting to finalize the first project. So in summary, we plan to submit our first project very soon, as early as next month is a possibility, and our second project we plan to submit in March of 2026. And I'd like to finish on a quote that a little science distances you from God, but a lot of science brings you closer to him. Thank you very much for your attention.
I would like to ask if patients with type 2 diabetes, do they receive pancreas kidney transplant?
So that's a really good question. You may have read articles where it happens, and it does happen. They're not considered the ideal candidates for multiple reasons, even though it does happen. So the first thing is you have to look at the type of diabetes. When you talk about type 1, it's autoimmune, it's destruction of the pancreas, so they do not make insulin, whereas in type 2 diabetes is about the uptake of insulin. And then you also have to look at the surgical aspect. So I can see a few surgeons in the room, including yourself, and patients with type 2 diabetes are often not considered ideal candidates for these type of major invasive surgeries. Because if you were to do a renal transplantation, okay, it's a big surgery, it's invasive. However, a pancreas transplantation as well, I think takes it to a whole new level. And thanks for your question. But it does happen in a lot of countries, they do it.
My question would be, I saw you had a lot of studies. What was the end of the risk of bias assessment, and what tool did you use for them?
So it's a really, really good question. We were quite strict with the risk of bias, so we had a lot of red and yellow colours going on there. We used 2 different tools, actually. So we used the Robbins I for comparative studies, so the risk of bias in non-randomized studies of interventions. So we used the Robbins I for comparative studies, and we used the minus tool for studies in which, from which we took single-arm data. So that's the methodological index of non-randomized studies, which actually has 12 domains. However, if you use the first 8, it's good enough for single-arm studies. So we used 2.
We always have this discussion regarding your number 2 project, but I think it could be interesting for the others as well. Why do you think it can be pulled together, hepatocellular carcinoma, which is the primary tumor of the liver, and the metastatic diseases like metastatic neuroendocrine tumors and metastatic colorectal tumor?
So it's a good question. We don't plan on pooling them together. We just plan on doing a really big meta-analysis that includes them all. So we plan on having multiple conclusions, but one sentence that will say, for X, Y, Z, yes, and for A, B, C, no. So it's not that we plan on pulling them together, we just plan on doing a comprehensive study that will look at all of these, if possible, to meta-analyze them.
Have you looked at some of the studies in your second project regarding oncological treatment before or perhaps after liver transplantation for the original cancer they get the liver transplantation for?
Yeah, so it's not an aspect I've delved into because when I was doing the feasibility of the project, I was looking at mainly the survival. But I think this is a really important topic that we'll have to delve into when it actually comes to executing the study. I think there'll be many more aspects that we'll have to look at.